Welcome back to the deep dive. We're here again, ready to take that pile of information, all the articles, research, the guidelines you've sent us, and turn it into something, well, useful, a roadmap.
That's the plan.
Today, we're diving into sources about procedures for peripheral arteries. The ones in your arms and legs.
Right.
Our goal. To help you understand what might be involved if you're looking at something called a peripheral arteriogram, maybe with angioplasty or a stent. We're building this guide just for you, straight from these documents.
Exactly. We're pulling together the key points from these research papers and clinical guidelines. Not adding our opinions, just synthesizing what's actually in the sources about this procedure and, crucially, what they say about staying healthy afterwards.
Okay, great. Let's get into it. We'll walk through what these sources tell us about getting ready, what actually happens during the procedure, and maybe most importantly, what you can do afterwards to help keep those arteries clear. So, first things first. Let's make sure we understand the procedure itself, based on these sources. It's called a peripheral arteriogram, sometimes with angioplasty or a stent. What does that actually mean in simple terms?
Well, fundamentally, these sources are talking about procedures for peripheral artery disease. That's when arteries in your limbs, usually your legs, get narrowed or blocked.
Okay.
An arteriogram, as these papers describe it, is basically a special kind of X-ray. It gives doctors a really detailed look inside those specific arteries.
Like a map of the inside.
Sort of, yeah. And when the sources mention angioplasty or stenting, they're talking about treatments they might do during that same procedure to open up any blockages they find.
Got it. So look inside and maybe fix a blockage if needed. Do the sources mention specific places in the legs where this happens often?
They do. They talk quite a bit about what they call endovascular revascularization. That just means fixing blood vessels from the inside using catheters.
Okay.
And they often mention doing this in arteries below the knee, the infrapopliteal arteries, and also in a main artery in the thigh, the superficial femoral artery. These seem to be common spots, according to the research.
Right. So specific target zones in the legs. How do they actually see the blockages and, steer things inside the artery?
A key technique mentioned is called digital subtraction angiography, or DSA. It's a sophisticated X-ray method. The sources say it's used both to confirm the diagnosis, to really see the narrowing, or stenosis, before they start, and then it acts like a guide during the intervention itself. It cleverly subtracts out the bones and tissues so you just see the arteries clearly.
Okay, so it's like their real-time map while they work.
Pretty much, yeah. The sources really emphasize how important it is for guiding things. They also mention that doctors are looking to see if the blockage is just in one small spot, a focal lesion they call it, or if the disease is more spread out.
And that difference matters for treatment.
It seems so. The document suggests that angioplasty, using a tiny balloon to push the artery open, or putting in a stent, that little mesh tube, to hold it open, are often used for those specific focal spots.
Okay, that makes sense. Targeting the specific problem area. Now, thinking about getting ready for something like this, what do the sources actually say about preparation? What does a patient need to do beforehand?
This is where it's important to remember what these sources are. They're mostly clinical studies and guidelines for doctors.
Right, not patient handouts.
Exactly. So you won't find a neat little checklist saying, do this, don't do that. But they talk a lot about certain things.
Like what?
Medications. Specifically, the ones many people with peripheral artery disease are already taking. Things like antiplatelet drugs, aspirin, and clopidogrel are common ones mentioned. And also blood thinners, anticoagulants. They list several, like rivaroxaban, warfarin, heparin, and others.
Okay, and those are usually for preventing clots, right?
Correct. The sources are clear that these medications are beneficial for people with PAD, procedure or not. Helps long term.
So they're important drugs.
Definitely. But, and this is a big but in the sources, they also talk a lot about the bleeding risk that comes with these medications. Especially when you combine them, like using two antiplatelets or an antiplatelet with certain anticoagulants, they compare risks of different combinations.
So even though the sources don't give you instructions like stop your aspirin 3 days before, the heavy focus on these specific meds and their bleeding risks strongly implies, well, it shouts, really, that your doctors will need to give you very specific instructions about managing these particular drugs before the procedure.
That's a very accurate takeaway from the source material. Adjusting those medications is clearly a major clinical consideration discussed in these papers. Even if the patient instructions aren't spelled out here, you absolutely shouldn't change anything on your own.
Definitely need to talk to the doctor about meds. Anything else lifestyle-wise to avoid right before?
Well, the sources mostly connect lifestyle to the cause and long-term management of PA. But one thing pops up repeatedly as being really important for outcomes, even around procedure time: stopping smoking.
Ah, smoking again.
Yeah. The sources call smoking cessation crucial. It's not exactly a don't do this the night before thing, but quitting is highlighted as vital for healing and long-term success.
That's a strong message. Okay, so let's say you've managed your meds as instructed, you're not smoking.
Yep.
You arrive at the hospital. What happens then, according to these documents?
Again, no check-in script, but they give clues about the medical prep. They mention different imaging tests, often done beforehand to plan things: CT scans, MRIs of the arteries, ultrasound. These help teams see the exact anatomy, the blockages.
So they have a detailed map before they start.
Precisely. And then they describe some general steps, probably drawn from surgical or vascular procedure contexts. Things like getting IV access, putting small lines in veins, usually in your arm, for fluids or meds. Giving antibiotics beforehand to prevent infection is mentioned. And of course, cleaning and prepping the area where they'll access the artery, usually the groin, and draping it to keep it sterile. Sometimes putting in a urinary catheter is mentioned too.
Okay, so standard prep. Lines in, cleaning the site, antibiotics. Got it. Now, for the main event, what happens during the actual procedure based on these sources?
Right. This is where the imaging, the arteriogram happens, and potentially the angioplasty or stenting. The sources are pretty specific about how they get into the artery.
How do they do that?
They frequently mention the common femoral artery. That's the big one high up in your groin area. It seems to be the standard entry point.
The groin, okay. Why?
It's large and relatively easy to get to, and it leads down towards the leg arteries. But the sources stress doing it carefully. They talk about using that live X-ray fluoroscopy to see landmarks, like the top of your thigh bone.
To guide the needle.
Exactly. Helps them puncture the artery accurately. They specifically mentioned being careful not to go too low near the skin crease and not to accidentally poke through the back wall of the artery.
Precision seems key.
Very much so. They even mention using a smaller needle, a micropuncture needle, sometimes. It might cause less damage if they need a couple of tries to get access.
Okay, so they get access carefully. Then how do they see inside?
That's where the contrast dye comes in, mentioned in the sources. They inject a special dye into the artery.
Ah, the dye.
Yep. And then, using that DSA imaging or fluoroscopy, the arteries light up on the screen. Doctors can clearly see where any narrowings or blockages are. The sources mention newer contrast agents are generally safer than some older ones.
So the dye makes the roadmap visible.
Exactly. And once they identify the problem spots, the stenosis or occlusion, if treatment is planned, they can proceed. The sources confirm they might use a balloon for angioplasty to push it open.
Right.
Or place a stent, that mesh tube, to prop it open.
Do they mention different kinds of stents?
They do. They talk about bare metal stents versus drug-eluting stents, which release medication slowly. They mention these being used in those arteries below the knee or in the thigh. They even touch on techniques for tricky spots, like where an artery splits.
Okay. Now, all this X-ray imaging, that means radiation, right? Do the sources talk about safety?
Yes, radiation safety during these procedures is discussed. They acknowledge that DSA and fluoroscopy use radiation, but they also describe ways clinicians limit the dose, like maybe using the high-detail DSA only for the most crucial steps and relying more on lower-dose fluoroscopy for general guidance. Modern systems might use road mapping, where an older image is laid over the live view, reducing the need for constant new X-rays.
Good to know they're thinking about limiting exposure. Okay, procedure's done. What about right afterwards in recovery?
Here, the sources we looked at are a bit less detailed from the patient's minute-by-minute perspective. But one thing comes up repeatedly in the context of managing PA patients and their meds.
Let me guess. Bleeding.
Bleeding, exactly. It's mentioned frequently as a potential issue.
From where they went into the artery.
That's one potential source, the access site. Plus, as we said, patients are often on blood thinners. So the source's focus on bleeding risk strongly implies that monitoring for any bleeding, especially at that groin puncture site, is a really critical part of the immediate post-procedure care.
Makes total sense. Keep an eye on the entry point. Okay, so looking beyond immediate recovery, what do the sources emphasize once you're discharged and heading home?
Here, the message from the sources is really strong and consistent. Guideline-directed medical therapy. Meaning sticking to the medication plan your doctors recommend. This is presented as absolutely fundamental for long-term management.
So taking the pills consistently.
Yes. Usually that includes the antiplatelet therapy we talked about, maybe anticoagulants too, depending on your specific situation. Sticking with these meds long-term is stressed.
And the research shows this actually helps after the procedure.
Definitely. The sources indicate continuing these meds significantly improves outcomes not just for your legs, but for your overall heart and vascular health too. It's a major point.
Okay, so medication adherence is key after discharge. What about watching out for problems? Any warning signs mentioned in these papers that you should look for at home?
This is a really important distinction to make. Based only on these specific clinical and research documents we reviewed, they do not provide a patient-friendly list of warning signs.
Really? So no, call your doctor if you see redness or feel this kind of pain?
That's correct. They discuss potential complications in medical terms like bleeding risk or artery dissection or reblockage, but not presented as a practical checklist of symptoms for you, the patient, to monitor at home.
Huh, so what's the takeaway there?
The big takeaway is that because these research-focused sources don't list those practical warning signs, it's absolutely essential that you get that specific list, what exactly to watch for, who to call, when to worry directly from your own medical team before you leave the hospital. That crucial, practical safety net information isn't in these papers.
That's a vital point. Don't rely on research papers for your specific warning signs. Get them from your doctor. Okay, while they might not list warning signs for you, the sources do seem to talk a lot about how to avoid problems recurring, right? How to prevent future blockages.
Oh, absolutely. This is where the sources place huge emphasis. They state very clearly that the core treatment for peripheral artery disease, beyond any procedure, relies on two things: lifestyle changes and aggressively managing the risk factors that cause the blockages in the first place.
Getting to the root cause.
Exactly. It's about preventing it from happening again or getting worse. The sources consistently link managing these factors to better long-term results. They list several key things.
Okay, what are they?
Number one, repeatedly called crucial, is stopping smoking. Quitting has major positive effects, according to these documents.
Quit smoking. Got it. What else?
Aggressively managing high blood pressure hypertension. Keeping it controlled is vital. They mention certain meds, like ACE inhibitors, seem particularly helpful based on the research cited.
Control blood pressure. Check.
Aggressively managing high cholesterol dyslipidemia. The sources show strongly that statin drugs lower the risk of serious leg problems, like amputation, and improve symptoms. They even talk about different intensities of statin treatment.
Manage cholesterol, likely with statins.
Aggressively managing diabetes, if you have it. That's another critical factor mentioned often.
Control blood sugar. Makes sense. Anything else?
Yes, exercise. Graded exercise prescription is the term used. Supervised exercise programs are highlighted as very effective for improving walking distance and how well people function. But home-based exercise is also noted as beneficial.
So based on these sources, avoiding recurrence really boils down to these big health habits. No smoking, control blood pressure, cholesterol, diabetes, and get regular exercise.
That's the absolute core message regarding prevention in these documents. While the procedure tackles the immediate blockage, this ongoing management of risk factors is presented as essential for long-term health and preventing progression.
Right. And that leads nicely into the idea of long-term management overall. Beyond procedures, what does that look like according to these sources?
Well, the sources describe long-term conservative management, meaning non-procedural management, as basically centering on exactly what we just discussed: the lifestyle changes and the guideline-recommended medical therapy.
So it's not like have the procedure and you're done. It's an ongoing thing.
Precisely. It's continuous. Keep managing the blood pressure, cholesterol, diabetes. Stay smoke-free. Keep up with regular exercise, whether it's a formal program or on your own. And crucially, keep taking the prescribed medications, the antiplatelets, statins, blood pressure meds, consistently.
And this whole package deal makes a difference long-term.
Yes, the sources clearly indicate that this comprehensive approach lifestyle plus consistent medical therapy improves not just cardiovascular health generally, but also functional capacity. Things like being able to walk further without pain, living more actively. It's about slowing the disease and improving quality of life.
So there you have it, our deep dive into what these particular sources tell us about navigating a peripheral artery procedure, from some clues about preparing, through the details of the procedure itself, and landing squarely on those crucial steps for long-term health afterwards. It seems really clear from this material that while a procedure can fix a specific spot, your active role in managing risks and sticking with medical advice is absolutely key.
It really is striking, isn't it, how consistently these different clinical sources hammer home the importance of lifestyle and medication. They aren't just afterthoughts. They're presented as completely fundamental, working right alongside any procedure. It's, like you said, not just fixing the plumbing for today, but looking after the whole system for the long haul.
Nurturing the whole system. I like that. And it really brings up a final thought, something for you to consider as you process all this. As you look ahead at managing your vascular health long term, based on everything the sources emphasized today, which part feels like it might be the biggest hurdle for you personally? Or maybe which change feels like it could make the biggest positive difference? Something to think about as you move forward on your own health journey.